towards this, I welcome Dr. Gomadi Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shanai, Program Coordinator. And today our expert faculty is Dr. K. Geeta. He is Associate Professor in Government Pilpok College, Chennai. Hearty welcome to you, Madam. And also I welcome Dr. Avini Skandan. He is the Senior Consultant in Astral MIMS, Kottakkal, near to Calicut. I welcome Dr. Avini. And now I pass on to Dr. Avini for the introduction of our faculty, expert faculty, Dr. Geeta.
Thank you so much, sir. So good evening, everybody. Like sir mentioned, we have a very eminent and experienced faculty with us today, Dr. K. Geeta. She has done her MD from Bernard Institute of Radiology at Madras Medical College, that is Madras Medical College. She has, after that, she's worked there as an assistant professor, and she's currently the associate professor at Pilpok Medical College, Chennai. She has had a Best Paper Award at State IRIA in 2011. She has been an invited speaker to multiple state and national conferences, published articles on MR mammogram, T2 stir space sequence, a cardiac chest MRI, CTS, MRCP in pancreatic duct injury, and so on and so forth. So we can understand by this itself that we have a very esteemed faculty with us. She has a lot of experience. And she is accompanied by 3 PGs of her institute, Dr. Swapna, Dr. Chokalingam, and Dr. Niveda. And they will be presenting, ma'am will be taking cases, a mock examination for them based on GUT and OBS Radiology, a collection of cases from their own institute. So over to you, Dr. Geeta.
Thank you, ma'am. Thank you, ma'am. In the outset, I like to thank the IRA Kerala Association for giving me the opportunity to present in this setting. Thank you, ma'am. Thank you, Avni, ma'am. Am I audible, ma'am?
Yes, yes, you are, Dr. Geeta.
Okay, ma'am. So I'll go on to presentation. I have 1 long case and 4 short cases, ma'am. So we'll start with long case. The first long case will be presented by Dr. Swapna. Dr. Swapna?
Yes, ma'am.
Yes,
ma'am. Okay.
So this is the clinical scenario of the first case.
Okay. 58-year-old male who came with a complaint of hematemesis, abdominal distension, and abdominal pain with a past history of gastrojejunostomy, which was done 20 years back. There's an X-ray abdomen of the same patient, which is showing diffuse homogeneous opacity, which is noted centralized in the abdomen, and it is extending to both the flanks, and there is no evidence of any focal calcification, or there is no evidence of any free air. And the visualized bony image shown appears normal. There is no evidence of any bony erosions or bony expansivation. With this X-ray, we could see only homogeneous opacity.
What happened to the bowel loops? You mentioned about bowel loops.
Seems to be displaced laterally, and
okay, there is a diffuse homogeneous opacity in the center of the abdomen, which displays the bowel loops laterally. What do you want to do next?
I would like to proceed with CT abdomen, ma'am.
CT abdomen, okay. You don't want to do ultrasound?
Okay, ultrasound. So these are axial sections of ultrasound abdomen, which is taken at the section of labor. And here I could see an heteroechoic, huge heteroechoic mass, which is seen in the subhepatic region in the first image. And in the second image, which is the same lesion, it is which is showing internal areas of necrosis with hypoechoic area in the center. and it seems to which is present anterior to the aorta. And in the third section, we could see there is on color Doppler, there is internal areas of vascularity, the lesion showing the highly vascular lesion. And
So what could be the possibilities? Any
could be
differentials?
With the limited cuts, it could be it is not
Okay.
originating from the liver. It could be any retroperitoneal mass or some
Okay.
highly vascular mass.
So this for completion, we have done barium also.
Okay, okay, ma'am. So there's a barium follow through, which is we could see opacified bowel loops, and here we could see that the bowel loops are displaced laterally and inferiorly, with centrally there are no bowel loops. And in the second image, I could see the stomach is displaced more of anteriorly and laterally.
So what's the use of barium series in this case, in this particular case? Anything?
So we need to rule out whether there is any primary relation within the bowel. Here, the bowel loops are per se appears normal because bowel loops are displaced. Moreover, there is no originating abnormality from the bowel loops, and displacement.
also-
With the help of displacement, we could see whether it is intraperitoneal or extraperitoneal.
Okay. Also, you have seen the history, history of GJ.
Gastrojejunostomy.
Okay. So the lesion is not arising from any from bubbles. Okay.
Yes, ma'am. Axial section of CT abdomen, which is taken at the level of kidneys. It is showing a heterodense mass lesion, which is occupying the anterior pararenal space, and it is displacing the bowel loops laterally, and there is no evidence of extension of the mass into the perirenal space, or there is no evidence of invasion to the kidneys, or neither is originating from the kidney. And so it is with this it is a retroperitoneal mass which is primarily occupying anterior pararenal space, and there is no calcification. Yes, ma'am.
What are the retroperitoneal organs, or how will you say it's a retroperitoneal mass?
Okay, ma'am. So retroperitoneal organs, it can be a primary or secondary retroperitoneal organ. So primary retroperitoneal organs are kidney, adrenal, ureter, aorta, IVC. And the secondary retroperitoneal organs, which is D2, D3, duodenum, pancreas, and ascending and descending colon. So we have three signs actually. That is beak
Only
sign.
3 signs. Okay. Okay.
Any retroperitoneal mass will be displacing the retroperitoneal mass, retroperitoneal organs anteriorly. Other than that, we have 3 signs. That is, beak sign means when a mass is
breaking mass, I think.
When a mass is originating from an organ, so that will deform the edges of the organ to a beak sign. So that is a positive beak sign, which will be seen when a mass is originating from a retroperitoneal organ. And embedded organ sign means that is when a mass is originating from organ, so that will be that seems to be like a mass is embedded within that organ, whereas when the mass is adjacent to an organ, so that will deform the shape of organ to lentiform or sickle shape. And so that is with embedded organ sign is positive, that is also indicative for retroperitoneal organ origination. And other sign is phantom organ sign, where mass, when a large mass is originating from a small organ, so that will so where it will obscure the or the organ of origin will be invisible for that to us. So these three are indicative of organ of origin, that is retroperitoneal organ or not. Other than that, feeding artery sign, ma'am.
Okay, good. So all these signs are negative, but still in the retroperitoneal space means then it's a
Secondary retroperitoneal mass.
primary retroperitoneal.
Primary,
mass.
sorry.
Okay.
So it is a axial section of contrast abdomen, where the lesion, which was previously mentioned, it is showing a heterogeneously enhancing lesion with internal areas of necrosis, and there are internal vascularity, and here we could there are multiple feeding vessels.
What are these?
The multiple
okay.
feeding vessels we could see, ma'am.
Okay.
And a
So
mass
these
is
are-
a huge mass, so it is displacing all the bubble loops peripherally, and it is occupying the entire upper abdomen.
Okay. What are these images?
Volume rendered images, ma'am. So this is
Oh.
also showing the same feeding vessels.
Okay. So any usefulness of these images to us or the clinician? So it may provide roadmap to the clinicians for any pre-op embolization of cases. So we can say the feeding vessel. Okay.
Okay.
So what are the signs you have told? Beak sign, embedded organ sign,
Phantom organ sign.
phantom organ sign.
Yes, ma'am.
And the feeding artery sign is sometimes if the renal artery is supplying the mass, could say it could be adrenal mass. Okay. From that prominent feeding artery sign can be applied. So how will we proceed now? What are the differentials? So I have seen, have told it's a retroperitoneal mass.
Retroperitoneal masses, they are widely classified into solid masses and cystic masses, ma'am. In solid,
No. Just compile your findings and say what is your diagnosis like.
okay.
Compile your findings and
okay, positive findings.
yes.
It is a huge dense, heterogeneously enhancing mass, which was seen occupying the entire pararenal space, pushing the all bubble loops laterally without invasion, without any signs of invasion into the adjacent organs or originating from any organ, and with the prominent feeding vessels and internal vascularity.
So moderate vascularity is there.
Yes, ma'am, with moderate vascularity. So malignant mass, which is originating from a retroperitoneal, so possibly retroperitoneal sarcoma. So it could be,
Okay.
since there is a fat density, so liposarcoma could be ruled out. And
so I have to see the morphology of the lesion to narrow down our differentials. Okay.
Yes.
So one is most common fat. So fat is not there. Then any other thing?
Leiomyosarcoma, it could be taken. It could be considered in this case because leiomyosarcoma is a heterogeneously enhancing lesion because there is also necrosis predominantly.
So for a leiomyosarcoma, I have to
there should be contiguity with IVC.
IVC. Okay.
Here it is not that well noted. So it could be malignant, undifferentiated pleomorphic sarcoma.
Okay, the differentials
yes.
could be just leiomyosarcoma
or malignant fibrous cytoma.
So, as nicely presented by Dr. Sapna, so the first step in this case is how to diagnose whether the origin of the lesion, which space it's origin, whether intraperitoneal or retroperitoneal. So if it's retroperitoneal, we have to see whether it's a arising from the retroperitoneal organ per se, such as pancreas, the colon, kidneys, adrenals, are the major retroperitoneal vessels. If it's not, you have to apply the signs. Next, we have to apply the 4 signs. That is a embedded organ sign, as it's depicted in this pictorial diagram. If its embedded organ is positive, if it arises from the kidney, then the embedded organ sign will be positive. And also, in this case, also you can see there is a beak-shaped appearance. Okay, so beak sign is positive means you can say the mass is arising from the kidney. If the beak sign, embedded organ sign, all the signs are negative. But in the retroperitoneal space, then you can say this is a mass from the primary this is a primary retroperitoneal mass. Okay, can apply all these 4 signs: embedded kidney sign, beak sign, and prominent feeding artery sign, and phantom organ sign. Phantom organ sign is mostly applied in adrenal lesions, where the small adrenal will be replaced by large mass. Okay, so next we have to proceed on to the imaging characteristics of the lesions. So whether it's a content, what is the content, whether it's a fat, if it's not fat, only necrosis and calcification. It could be teratoma also, the retroperitoneal teratoma, and also a myelolipoma, extramedullary hematopoiesis also have a fat. And the other differentials, if it's moderately vascular and necrosis, means it's definitely malignant aggressive tumor, mostly sarcomas. So if it's in contiguous with the IVC, can think in terms of leiomyosarcoma, or other differentials could be undifferentiated pleomorphic sarcoma. So what is the diagnostic algorithm in case of retroperitoneal masses in adults? As I said previously, if it's fat, it could be liposarcoma, teratoma, extramedullary hematopoiesis, or extramedullary myelolipoma, and also lymphangioma, where we can see the chylous content. And with the myxoid stroma, it could be myxoid liposarcoma or myxoid fibrosarcoma. Okay, so with the necrosis, it suggests aggressiveness. So as in our case, we can see the necrosis. So it could be pleomorphic liposarcoma, or undifferentiated pleomorphic sarcoma, or leiomyosarcoma. But our case is actually biopsy proven malignant fibrous histiocytoma actually. So other differentials in retroperitoneal masses as important. The lymphoma we are seeing cases of lymphoma. So here there won't be any infiltration. There won't be any gross infiltration of adjacent organs. So there will be mantle zone of growth pattern, lymphoma, Erdheim-Chester disease, and retroperitoneal fibrosis. So this is a diagnostic algorithm. So in a retroperitoneal mass, we have to see the origin of the lesion, whether it's a retroperitoneal or intraperitoneal, and if it's retroperitoneal, whether it's from the organ, or if it's not from any retroperitoneal organ, it could be primary retroperitoneal mass. With imaging characteristics, we can further down the differentials, but HP is ultimate. So you can say in this case, it could be sarcoma, but we can't say definitely the pathological diagnosis. So in this case, it turned out to be, so this is a diagnosis in our first case is primary retroperitoneal malignant mass and HP proven malignant fibrous histiocytoma. We'll move on to second case, ma'am. So we'll want to short case 1. This case will be presented by Dr. Chokkalingam.
Very good evening, ma'am. Yes, ma'am. 39-year-old female presenting with history of weakness of all 4 limbs and history of vomiting, history of giddiness, and history of diarrhea, and history of recently diagnosed hypertension on tablet amlodipine, and a history of similar episodes 2 times in the past 1 year. And the patient has recovered with oral potassium supplementation.
So next, the lab values are given.
So the lab values show severe hypokalemia where the potassium is around 1.6 milliequivalents, and there's a significant increase in aldosterone level, the 596 picogram, and also shows ABG shows a metabolic alkalosis.
Okay, so the next investigation have limited images in this case.
Okay. So it is a axial section of a plain CT showing a bulky right adrenal gland, especially involving the medial limb, with a Hounsfield unit of 10. So, yes, ma'am.
So what is the possibility? Bulky means, and the size, what do you want to do next?
Next, I would definitely want to know the size of the lesion, ma'am.
So the size of the lesion is 2 centimeter by 1.3 into 1 centimeter.
Okay, then I would do a washout study, ma'am.
What washout study?
Adrenal washout study, ma'am. In adrenal washout study, I use the Hounsfield unit in the plain imaging, and then in the Hounsfield unit in the venous phase and the Hounsfield unit in the delayed phase, ma'am. By using that, I use the formula, ma'am. Absolute
Okay.
washout and relative washout, ma'am.
Okay. This is the contrast image at 1 minute.
Yes, from the lesion shows a smooth homogeneous enhancement with the Hounsfield unit of 50. And in 15 minutes, in the delayed phase, the lesion shows an Hounsfield unit of 20. So using that formula, the absolute washout is calculated by a formula of enhanced HU minus delayed HU divided by enhanced HU minus non-enhanced HU, ma'am. So by that, we could get it around 50 minus 20 by 50 minus 10, which would be around 30 by 40. So it would be around 3 by 4. So it would be around absolute washout would be around 75%, ma'am. So
what is your interpretation? 75%.
If the absolute washout is more than 60% and the relative washout is more than 40%, it signifies towards an adrenal adenoma, ma'am.
Okay. So if the washout is more,
Yes,
it
ma'am.
will be benign.
Benign,
As in contrast to other liver HCC and all, you will see the washout is more. You have to think in terms of carcinoma. Whereas in adrenal, it's benign. Okay.
Yes, ma'am.
So what will you do next?
Ma'am, I will just progress it with an MRI, ma'am. In MRI, I would do a T1 in-phase imaging and an opposing phase imaging, ma'am.
Okay. So which one is opposed phase? Which one is in phase?
The image in the left is the opposing phase, and the
Left.
right is the in phase, ma'am.
This one is.
That opposing.
Can you see
phase.
the point? Why opposed phase? How will you identify
the fat and the non-fat interface becomes suppressed in the opposing phase, ma'am.
Okay, not only so we can see the artifact, no Indian ink artifact.
I can also see the Indian ink artifact. Yes, ma'am.
Artifact, we can nicely say this is a opposed phase images. And what happened to the lesion?
The lesion
signal.
The signal is completely suppressed in the opposing phase, ma'am.
Signal dropout is there in opposed phase.
Yes, ma'am.
So, what is the use of this opposed phase imaging?
Why
can't we do T1 fat sat instead of opposed phase? We want to know the lipoma, no, lipid poor or lipid rich. Okay.
Yes, okay.
So why can't you use T1 fat sat instead of this one in phase opposed phase? What is this? What is the use of this?
To suppress the microscopic fat, ma'am.
Okay, very good. To see the microscopic fat, we have to use in phase opposed phase. For macroscopic fat, we have to see the T1 fat cell.
Yes, ma'am.
So what is your diagnosis with this? Compile your findings
this is
from clinical CT washout study and with MRI.
Yes, ma'am. A patient presenting with an hypertension, with metabolic alkalosis, hypokalemia, and with an absolute washout of around 75%, shows it towards a functioning adenoma, ma'am.
Okay, functioning adenoma.
Yes, ma'am.
Why the aldosterone levels are increased?
Yes, ma'am.
So for how many percentage will be functioning adenomas? We have seen adenoma cases, no?
Around 60% adenomas are functioning, ma'am.
60%. Huh? So the patient has hypertension, hypokalemic paralysis, metabolic alkalosis with increased aldosterone level, and the CT also shows adenoma and washout. We have seen greater percentage of washout. So it's lipid-rich adenoma as confirmed in phase opposed phase images. So this is the case of functioning adrenal adenoma. The differentials could be
Conn syndrome, ma'am.
yeah.
Conn syndrome.
Any other differentials for Conn syndrome?
Ma'am, conditions with secondary hyperaldosteronism such as Bartus and Gettelman syndrome can present to similar to.
Okay, so is their patients also hypertensive? Okay, we'll move on to discussion. So as we did in our case, we have to see the size of the lesion. Okay, So first, the size of the lesion should be, if it's less than 1 centimeter, it's normal. 1 to 4 centimeter indeterminate, we have to proceed with the CT HU value. The HU value is more than 10, we have to proceed with washout studies as we did in our case. And if the washout is there and a signal drop, it's a lipid poor adenoma. Whereas no washout and no drop, it could be malignant lesions. If it's a high vascular pheochromocytoma, the large lesion with necrosis, adrenal cortical carcinoma, it could be bilateral, or in lung carcinoma, it could be metastasis also. So next we have to, the formulas we apply in CT are absolute washout and relative washout. The absolute washout we have to calculate with the enhanced CT minus 50 minutes delayed CT divided by enhanced CTHU minus unenhanced CT of a percentage, 100%. And if for the relative washout, we'll be detecting enhanced CT minus delayed CT at 50 minutes and divided by enhanced CT at 1 minute into 100%. So if the absolute washout is more than 60%, it's an adenoma, and the relative washout also more than 40% is adenoma. So benign. And mostly in MRI, we visually calculate the signal dropout. We can also keep RO, and we can calculate the signal intensity. So adrenal to spleen ratio is calculated by lesion signal intensity in opposed phase divided by spleen signal intensity in opposed phase, divided by lesion signal intensity in phase divided by spleen signal intensity in phase. And the signal intensity index is calculated by lesion signal intensity in phase subtracted with the lesion signal intensity in opposed phase divided by lesion signal intensity in phase and multiplied by 100%. So if the adrenal to spleen ratio is less than 0.71, it suggests adenoma, whereas the signal index is more than 16.5%, it suggests adenoma. So usually we do visual calculation, only we'll see the dropout. We can also calculate this ratio, adrenal to spleen ratio or a signal SI index. So in our case, the differentials are Conn syndrome, as we have seen the increased aldosterone levels, and also the patient is hypertensive and with the hypokalemic paralysis and metabolic alkalosis. The other differentials are Gitelman syndrome and Bartter syndrome. But in Gitelman's syndrome and Bartter syndrome, though clinical features are similar with the increased aldosterone level, in the both conditions, the patient is normotensive instead of high levels of plasma renin. And also Conn syndrome, the other causes for primary aldosterone is other than Conn syndrome is bilateral adrenal hyperplasia, and very rarely adrenal cortical carcinomas can also cause primary hyperaldosteronism. So our case diagnosis is functioning adrenal adenoma, Conn syndrome. So we'll move on to second short case.
Yes, ma'am. Good evening, ma'am. Swapna, can you share your this thing? I think the X-ray is
Oh, yes, ma'am.
I think in iPad, I think these images are turned out. Can you share only
okay, ma'am.
case? Okay. I think the rest of the images are okay. Dr. Nivedita.
Yes, ma'am.
So,
shall I share, ma'am?
I have to do stop sharing, yeah?
Yes, ma'am. Good evening, ma'am.
Okay, we'll start the short case, second short case. So Dr. Nivedita will be presenting this short case.
Yes, ma'am. This is a CT scanner image, which is showing multiple mottled areas of multiple mottled gas noted within the right lumbar region. So rest of the abdomen and the skeleton appear normal. So the possible DDs would be with this is emphysematous pyelonephritis,
other things to be considered is it could be of GI gas itself, or it could be from a gas within the abscesses, or from any urological interventions, or it could be from any GI or GU fistulas, ma'am. So I would like to proceed with the CT.
Okay. Next slide. Next slide, Swapna.
So serial axial section of non-contrast CT showing multiple air pockets, which is noted within the pelvic axial system, renal parenchyma, and also within the perinephric spaces, and also within the perinephric space, ma'am.
Okay.
So this gives a, and there is no any fluid collections over here.
Okay.
Also, there is no any fluid collections.
Even limited sections, there is no obvious fluid collection, perirenal fluid collection noted. Okay.
Fluid collections are noted, ma'am.
So your diagnosis, straightforward case of
Emphysematous pyelonephritis, ma'am. It's a type 1 emphysematous pyelonephritis.
next slide. We have few more images, I think so, on the
Yes,
contrast. Next slide.
this is a excretory urographic image. Just showing this right kidney is a right kidney shows contrast excretion, and
so there's, you can very well see the air pockets in the pelvic calyces system, and also there is a perinephric fat stranding. You can see the right renal fascia thickening, no? Perinephric fat strand.
And the facial thickenings are seen.
Okay.
So the diagnosis would be, so my diagnosis is right emphysematous type 2, type 1 pyelonephritis. This belongs to the class 3A.
Okay. What is type 1 and type 2? So previously, there will be CT classification based on type 1 and type 2.
Yes.
Based on the immunity and the prognosis, for the prognosis. What is type 1 and type 2?
Type 1 that will be having only greater than 1/3 of parenchymal destruction, ma'am, and it will be having a streaky or mottled gas pattern, and there won't be any fluid collection. So fluid collection indicates immunity, ma'am. So if it is there won't be any fluid collection, which means this patient is having a bad prognosis. And this type 1 will be having more mortality, whereas type 2 will be having only less than 1/3 of parenchymal destruction, and fluid collections will be there. So, and the mortality is comparatively less. Ma'am.
Okay. What is the recent classification we are following now for emphysematous pyelonephritis? On the treatment based on this only we are.
Yes. Based on this is a CT classification. We are now using Huang-Sun classification, ma'am. So where the class 1 is within the collecting system, class 2 is within the renal parenchyma, whereas class 3A is within the perinephric space. 3B is breaching the fascia and entered into the pararenal space. 4 is in both kidney or emphysematous pyelonephritis in a solitary kidney, ma'am.
Okay. What is perinephric space and what is pararenal space?
The perinephric space is which is the space between the renal capsule and the renal fascia, ma'am. Anteriorly genital fascia, posteriorly zuckercandle fascia. That is space, ma'am. Pararenal space is between the perinephric fascia and between the perinephric fascias and that is to the adjacent tissues like a psoas muscle. That is a pararenal space, ma'am.
Okay. So next slide. So what is the diagnosis in this case? What is a type?
This is a type 1 emphysematous pyelonephritis, class 3A, ma'am.
Niveta?
Ma'am? Ma'am?
Niveta?
Ma'am? Yes, ma'am.
audible, no?
Yes, ma'am. Ma'am, am I audible, ma'am?
I couldn't hear you.
Ma'am, audible, ma'am? Am I audible, ma'am?
Okay. Yeah. Now you are.
Ah,
Yeah.
okay.
Yes. Now audible.
Yes,
So
ma'am.
final diagnosis. Okay.
Yes.
So this is probably class 3A
Emphysematous pyelonephritis, ma'am.
pyelonephritis. So what will you do? Any role? Still our role is there or not? Only
Yes.
diagnosis.
Yes, ma'am. The main first of all, they have to resuscitate the patient. The patient will be in shock, and then we have to. They have.
So you have to ask the history. Any other risk factors? You have to ask the history of what history you will be asking. So I haven't given any history to this patient, this particular patient. No?
You have to ask about the history of diabetes mellitus because 90% will be diabetic, and the patient will mostly other than diabetic, we have to ask for any immunocompromised history, ma'am.
Okay.
Oh, these are
Then-
risk factors. So we have to do resuscitation and do the diabetic control.
Creatinine level,
Yes.
creatinine, obesity.
Okay, ma'am.
So many high risk factors we have to ask. Okay.
And then
Management.
management will be IV antibiotics and diabetic control, resuscitate the patient. Then we have to in our role we have to do percutaneous catheter drainage, ma'am. Under the radiological guidance, we have to do that.
Either ultrasound guided or CT guided. You can do.
Yes, ma'am. Ultrasound guided itself we can do, ma'am.
Okay. So how will you approach the percutaneous drainage?
Percutaneous catheter drainage, the patient should be in a prone position and the pelvic alysial system should be, we should first target the pelvic alysial system and then the catheter should be inserted within the pelvic alysial system. And then
It's only collection, you can directly put in the perirenal space also, can drain the collection.
collection. Yes, ma'am.
Okay. So if it's in intraparenchymal, what approach you will do? Any particular approach? Or
in the intraparenchymal means we have to go through the Brody's avascular zone, ma'am. That is avascular because there will be that will be the junction point for the meeting of anterior and posterior segmental artery. So that looks avascular. So that approach leads to minimal bleeding, ma'am.
okay, good. So next slide, we'll move on to discussion, short discussion of this case or division. So as she said, okay, I'll proceed. As Nimeta said, the CT features of emphysematous pyelonephritis may be classified into type 1 or type 2. So type 1 will be in the air involvement will be more than destruction of the renal parenchyma will be more greater than 1/3 with the no perirenal or intrarenal fluid collections. So it has an suppressed immunity and the prognosis will be poor. They have a higher mortality. Whereas in type 2, there will be extrarenal collection. The destruction also will be less than 1/3 of the parenchyma. So the mortality and the prognosis is good in type 2. But now we are classifying according to Huang Singh et al. Where the class 1 is the gas in the collecting system only, whereas class 2 is the air in the renal parenchyma without extension, without extrarenal extension, whereas in 3 it is divided into 3A and B, where 3A the extension of air or the abscess into the perinephric space and 3B into the pararenal space, and class 4 is the bilateral emphysematous pyelonephritis which affects both kidneys, or if it's solitary kidney also class 4. So next slide. So this is a picture to depict the perirenal and pararenal space. The perinephric space was an area between the fibrous renal capsule and the renal fascia, whereas the pararenal space was the space beyond the renal fascia extending into the adjacent tissues. Okay. So this we can divide into 3A or 3B. So how will you manage emphysematous pyelonephritis. So as we have to do initial KUB. So Nivetha, how will you differentiate X-ray KUB from X-ray abdomen?
Ma'am, KUB includes the bladder, ma'am. Kidneys, ureter, and the bladder.
And whereas abdomen, anything
External,
particular?
from the diaphragm up to the
Abdomen includes both diaphragm. Okay. In X-ray abdomen, usually diaphragm is visualized.
ma'am.
Yeah. So the management, the slide is okay, linking. So the management is so you have to go for initial X-ray KUB. You have to classify whether it's a class 1, 2, 3 as we saw earlier. So in the class 1 and 2, we have to go with fluid electrolyte and diabetic means a glucose control and IV antibiotics. And then we can go for, if needed, we can go for percutaneous catheter drainage depending upon the case if it's not treated with the conservative management. And for class 3A and B, we have to assess the risk group, whether the high risk group or a low risk group, depending upon the risk factors like diabetes, obesity, and increased creatinine level, and all those things we have to taken into account. And then we have to either with ICU, with IV antibiotics, we can go for nephrectomy. Whereas in class 4, if it's as it is involved bilaterally, we have to first proceed with the percutaneous catheter drainage. If it's failure, we have to proceed with the nephrectomy. Okay. So this is for this case. We'll move on to next case. So we have seen one long case, 2 short cases. This is the 3rd short case. Okay. Am I right?
Yes.
So 3rd short case will be presented by Dr. Swapna. So I have given the history.
Yes, ma'am. 23-year-old Primey who was admitted for a poor glycemic control and random blood sugar was showing more than 500 milligrams.
Next slide.
There's an antenatal ultrasound of the same patient, which is showing the biophysical profile of BPD. In the first slide, we could see the biparatal diameter was corresponding to 20 weeks gestation, and abdominal circumference of the same showing which corresponds to 18 weeks and 5 days. And
so next slide. I went on to next slide. Okay.
There's a section which is here we could see there is a defect which is seen in the anterior abdominal wall, noted at midline, noted in midline, and with the herniation of bowel, and since there is internal, it seems to be hyperechoic, it must be bowel and liver as a content of hernia. And in the second image also I could see the same. So a defect noted in the anterior abdominal wall with herniation of bowel and liver as content, which is more
and any
yes, ma'am.
Any walled off or any membrane is there, or
Here
it's a free floating bowel loops, I have to say.
Free floating, ma'am. It is not free floating into the amniotic membrane. It is contained within amniotic sac. In this image, I could see a membrane.
Okay.
Membrane, which is outlining that hernial sac. And in the second image on color Doppler, I could see the umbilical cord, which is inserting at the tip of hernial sac. So,
so what else you want to do? You probably know the diagnosis by this. So what else you don't want anything to do? You don't want to do the fetal survey?
yes, ma'am. So it with
so what is this
finding,
diagnosis?
It is
with this image, can say?
Yes, ma'am. Omphalocele, ma'am. With these findings,
Sapna?
Yes,
I don't think so. You are audible.
Ma'am, am I audible, ma'am? Hello, ma'am. Ma'am, am I audible, ma'am?
Yes, Dr. Swapna, you're audible. Actually, I think Dr. Geeta has some issue with the network.
Okay, ma'am.
Dr.
Swapna?
Geeta?
Yes, ma'am. Am I audible, ma'am?
Yes,
Ah,
ma'am. Now you are
okay,
audible.
ma'am.
Yeah. Yeah. So,
So
what is
with
your
all these
diagnosis?
findings, my possible diagnosis will be omphalocele, which is showing a defect
Okay.
in the central midline in the anterior abdominal wall with herniation of bowel and liver as content, which is contained within membrane. So, and on color Doppler with umbilical cord insertion at the tip of hernial sac. So it must be an omphalocele. So we need to look for whether we have to look for any other associated anomalies, since omphalocele is most commonly associated with other anomalies and trisomies. So we have to do general screening of all other systems, ma'am.
So in this case, all other fetal survey is normal means
Yes, ma'am. It is
Mm.
normal.
this is in this case it's normal. So this is could be a
Iris is
Is
sporadic,
it-
isolated omphalocele. It's an isolated
Okay.
omphalocele. So it has a good prognosis comparatively. So the mortality will be around 10%. When it is associated with other anomalies, other chromosomal anomalies, it is 1%. And if it is associated with, in addition to that, cardiovascular anomaly, the mortality will increase up to 100%, ma'am.
Okay. So what is physiological herniation? I forgot to ask previously.
Physiological herniation has to be differentiated from the omphalocele, where the physiological herniation, the defect size will be more of a smaller. It will be around less than 7 mm, ma'am.
What weeks we will be seeing physiological herniation?
What, ma'am?
Which week you will be seeing physiological herniation?
It is seen around 10 to 12 weeks, ma'am. If it persists even after 12 weeks, means we have to.
It is starting at 8 weeks itself. We can see it will be persisting till 12 weeks generally. Very rarely it may persist up to 16 weeks.
Okay, ma'am.
Mm.
And the content will be in physiological herniation. It will be only bowel, ma'am. There won't be any other abdominal, like a liver or any other abdominal organs won't be there in physiological herniation. And
Okay.
size differentiate.
So, how will you differentiate omphalocele from gastrocasis?
Gastroschisis is more of a paramedian defect, ma'am. It is more towards the right side. The defect will be more in the right side. And the bowel loops, which is herniating, it will be freely floating in the amniotic membrane. That is, it won't be having any covering amnion or peritoneum in the hernia. And the association that is anomalies, it was not that associated with anomalies as seen in omphalocele. So comparatively, the prognosis will be better in gastroschisis than compared to omphalocele.
So what are the associated anomalies or syndromes with omphalocele? What are the associated syndromes?
Syndromes is Beckwith-Wiedemann syndrome and pentology of Cantrell syndrome. So pentology of Cantrell, which is mainly involving the sternal defect, ectopia cordis, diaphragm defect, and any cardiovascular anomalies, that is VST, AST, and TOF, and in addition to that, omphalocele will be there.
What is OEIS complex?
OEIS, it is omphalocele, exostrophy, imperforate anus, and sacral agenesis, ma'am.
So with the cloacal extrophy and the bladder extrophy will be infraumbilical anterior abdominal defect. With the spinal defect, it will be okay. So this is a case of central omphalocele. Okay. What you said, pentology of Cantrell is an epigastric type of omphalocele. OES complex is an infraumbilical type of omphalocele.
Okay.
So any role, how will you counsel the patient on what will you suggest?
So I would like to do further proceed with the echo, ma'am, since it is most commonly associated with cardiovascular anomaly. So we need to do echo to rule out any cardiac structure and functional anomalies and any other cardiac anomalies. And we have to screen all other systems in addition. So for that, I would like to do fetal MRI. I would to do, ma'am. So to quantify the defect and to look for other associated anomalies for lung volume.
How to rule out pulmonary hyperplasia also. Okay.
Yes, ma'am.
So if it's everything is normal, if sporadic, you have to follow up the case and you have to go for a multidisciplinary approach and treatment. Okay. With maybe have to go for 36 weeks C-section also. If it's not associated with any. What are the trisomies or other anomalies associated with the omphalocele?
Most commonly, it is trisomy 18 is most common associated with that. Other than that, it is 13 and 21. Turners and Klinefelters are also
13, 18 also. Oh, okay.
yes, ma'am. 18, 21.
So all other systems will be involved, cardiac, GIT,
Yes, ma'am.
MSK. Okay. And okay, we'll move on to discussion. So in this case, the fetal survey is, rest of the fetal survey is normal. So it's a sporadic case, okay, isolated. So in the findings here are, and the HC and BPDFL corresponding to 22 weeks, whereas abdominal circumference corresponding to 19 weeks with central anterior abdominal wall defect with liver at its content, okay. So the mass is encompassed by the umbilical cord. We can nicely see in the limiting membrane and also umbilical cord. And all other system being normal. This is a, next slide, this is a central omphalocele. So how will you approach this kind of omphalocele or anterior abdominal wall defects? We have to look for the location of the umbilical cord insertion. So I have to see the defect, anterior abdominal wall defect, whether it's the defect is into the right of umbilical cord insertion. Have to think in some terms of gastrocases, and also there will be no membranes. Whereas if the defect is below the umbilical cord insertion, it could be infraumbilical type of omphalocele, that is OEIS complex, where it will be associated with spinal defect, imperforate anus, and bladder or cloacal extrophy. Whereas defect may include cord insertion, it's a cloacal extrophy. And with no extruded bubble, only low cord insertion, it's a bladder extrophy. Okay, these are our infraumbilical type of anterior abdominal defects. Whereas if the defect is seen above the umbilical cord insertion, and we have to look for the inferior sternal defect with the ectopia cordis, that is the pentalogy of Cantrell, she said already. Okay, so as in our case, the umbilical cord inserts onto the defect. This is a central omphalocele. This our case is a central omphalocele. So if there is no definite pattern and the amniotic band syndrome, obviously we can see the multiple contractures, though it will be small, milder type of contractures. Whereas in other complex thing where that is the body stalk anomaly and the limb body wall complex and all, there will be major limb defects. Okay, that will be subtyped according to that, whether it's a dominant in limb defects or dominant in abdominal wall defects. Where the body stalk anomaly will be dominant in abdominal wall defects, it will be presenting with limb defects also, but the dominance will be in the abdominal wall defects. Whereas in the limb body wall complex, there will be a dominant limb defects. Here the limb contractures and this will be gross compared to the amniotic band syndrome. So this about these differentials for these herniations and the anterior abdominal wall defects.
Okay.
We'll move on to last case. Okay, it's almost next case. Chakalingam can present this case, no?
Yes. Could see a 44-year-old female, serial, it's an axial section of delayed CT urogram with cystogram, and we could see a contrast extravasation into the perivesical space, which is also seen extravasating into the deep muscular compartment in the left inguinal region. Yes.
Not audible. Huh?
Could you hear me, ma'am?
I couldn't hear you properly.
1 minute.
Avni, ma'am.
Ma'am, actually, he is audible.
Yeah.
Okay, ma'am. Avni only. Okay.
We can hear both of you.
Okay.
Thank you. There's a contrast extravasation into the perivesical space and into the deep muscular compartment of the left inguinal region, ma'am. So it's probably a case of
So what study is this? What study? Can you say?
CT cystogram, ma'am. Hello, ma'am.
Whether it's a delayed CT,
delayed CT urogram with
CT KUB with delayed XPT urogram or any other else?
cystogram, ma'am. Ma'am, could you hear me, ma'am? It's a CT cystogram.
Yeah.
Yes,
what is CT cystogram? What is direct CT cystogram? What is indirect CT cystogram?
Direct CT cystogram is done by using a saline infused distilled contrast, ma'am. In about 300 ml distilled saline contrast is used, ma'am, in the ratio of 1:10, ma'am. Whereas the indirect, we use the IV contrast medium and take a delayed picture to establish any bladder injury, ma'am. Hello, ma'am.
Okay. So diagnosis?
So it's a case of an extraperitoneal bladder rupture, ma'am.
So how will you differentiate extraperitoneal bladder rupture from intraperitoneal bladder rupture?
Usually an intraperitoneal bladder rupture, you could see the contrast extravasating into the peritoneal spaces, ma'am, where it may line the peritoneal layering into the mesentery and into the bowel loops, ma'am. Whereas in case of an extraperitoneal bladder rupture, it may be classified into simple or a complex type, ma'am. In simple type, you could see the contrast extravasating in the perivesicle or in the prevesical space of Retzius, ma'am. Whereas in a complex type, you could see the contrast extravasating into the inguinal region or into the thigh, ma'am.
Okay, as our case is complex. What else you will have to see? Any other associations?
To look for any pelvic fractures, ma'am.
Good. Okay. So what are the signs?
A flame-shaped contrast around the bladder or a molar tooth sign signifies extraperitoneal bladder rupture, ma'am.
Okay. Next slide.
So here you.
So this is another case, same diagnosis. Okay.
Yes, ma'am.
Okay. You can see the Foley's with the molar tooth appearance in extraperitoneal rupture. Okay.
Yes.
Contrast exposition. So we'll move on to discussion. Next slide. So I have put a pictorial representation for a flame shaped. Okay.
Okay.
So flame. Next. So this is the molar tooth appearance in the extraperitoneal rupture. So difference between extraperitoneal and intraperitoneal, as you said. The next slide. So I have extraperitoneal rupture. So the most common site will be anterolateral near the base, whereas in intraperitoneal bladder dome, the mode of injury will be penetrating and will be associated with pelvic bone fractures. Whereas in extraperitoneal, the urine extravasation or the contrast extravasation in CT will be in the pre and paravesical space and also presacral and inguinal region and upper thigh. And the appearances will be the molar tooth or flame shaped with the streaky contrast giving the flame shaped appearance. Whereas in intraperitoneal, it outlines the peritoneal recesses and the bowel loops. And the intraperitoneal is less common compared to extraperitoneal. So for most of the suspected pelvic fractures, we have to rule out bladder rupture. And in case you have to do, you can wait as in case of delayed urogram also we can see whether the contrast extravasation, and we can do direct CT cystogram with injecting contrast with saline with infusion with contrast directly via the Foley's. But we have to check whether we have to rule out prior with any urethral injuries there or not. You have to rule out. Patient is already with Foley's, we can do direct CT cystogram. Next slide. So direct CT cystogram, instead of antegrade opacification of urinary system with CT urography, contrast is instilled retrograde into the patient's bladder, and then pelvis is imaged with CT. In this procedure, the technique is you have to drain the urine from the bladder via Foley's or suprapubic catheter, and in case of trauma setting with the possible pelvic injury, you have to rule out the first. You have to exclude first urethral injury. Okay, then the dilute water soluble contrast is hung to instill the contrast into the bladder under gravity pressure, and the dilution ratio is about 1 in 10%. Okay, so similar to conventional cytography, you have to fill the contrast until the patient urges to void, or if it's almost more than 300 ml, we can administer. So we will be doing this direct cystogram in the trauma settings. Okay, so this is a extraperitoneal bladder rupture. I think I don't have the short case. Maybe spot or next slide. This is not actually short case. This is spot or Swapna. Anybody? Chokalingam.
IUCD. Placed IUCD.
Misplaced IUCD. So you can see the T-shaped radio opacity in the
Yes, ma'am.
right lumbar region. Okay. So this is a misplaced IUCD. Actually, I have deleted this slide maybe. Okay. Okay, thank you. Nice presentation by all our PGs. Thank you, ma'am. Thank you, Avni, ma'am.
Thank you. Thank you.
All the organizers.
Thank you.
Thank you, sir.
Thank you, ma'am. I'll first let Venu sir speak. Venu sir.
Yeah. All the what I feel now, the long case, the one long case and the 4 short cases now, all the cases were presented nicely by the PGs, and also it was discussed in detail and systematically by the faculty, Dr. Geeta. And the cases are, I mean, not that much common now, especially the emphysematous pyelonephritis, okay, but otherwise the cons, usually we are actually not looking at the biochemical values and all. We will be just putting it as adenoma and then we will leave it now. So probably that may turn out to be functioning adenoma. And what about the retroperitoneal mass discussion, and then omphalocele, everything. Very systematically it was presented and discussed. Thank you very much. Thank you, Dr. Geeta, and all the PGs. All of you actually presented very well. Okay, thank you very much.
Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you so much, Venu sir. Like what Venu sir said, your collection of cases itself was very nice. And it went, and you finally accidentally ended up giving a bonus case also. So that was also nice.
Thank you, ma'am.
And so that shows, I mean, you have a good collection of cases, and your the approach even for the PGs, they are going in a very systematic manner. So that itself shows how they are being trained. And that is what we want the PGs to know, how to approach the cases. It's not just we knowing it, but how we present it is very important. And the kind of questions that will get asked during the exam. So you gave us a very good feel of that. And even a lot of clinical perspective. And like sir mentioned, the lab values, which we don't pay attention to. So those kind of things also you gave a lot of importance and stressed on it. So thank you so much. That is like, we are so used to being couch radiologists and not going beyond what we are actually our images. So thank you for stressing on that. It was good.
Okay.
Somebody
they
asked for the spotter answer,
spotter,
ma'am.
spotter, yeah. Swapna, you can say again the diagnosis.
Misplaced IUCD, ma'am.
You can show the arrow.
I hope you heard that, Kritika. There is a misplaced IUD in the right electrode.
Very well. It's easy. It's out of the way from the pelvis. If it's within the pelvis, you have to put that angle and all. You have to measure that whether it's the uterine. This thing have to put some values, and triangle you have to put, and you have to say it's within the uterus or outside. But this case is clear cut. It's outside the pelvis itself. So it's a misplaced. You have to look all the corners, and you have to see the abnormal radio opacities to make a spot diagnosis.
That is where the importance of a structured approach, not just jumping in and seeing what we normally just see. So thank you so much, ma'am. And thank you, Dr. Geeta. Thank you, Dr. Swapna, Nivedita, Chakalingam, all of you.
Thank you,
very nicely. And thank you, Venu sir, for after his busy work, he comes and he diligently monitors and guides us and is always there with us. Thank you so much, Venu sir. Thank you, Ramesh sir, for always being the backbone, being with us. And most importantly, I didn't mention the president, Dr. Gomati ma'am and Dr. Rijo sir's name first, because they're not right now in the panel here. but they are the ones who keep driving us right from the front. So thank you so much, because we have such great people to lead us, and from the front, we always keep pushing for more. Kerala IRIA has regular sessions of academics. So I hope everybody makes the most of it. There's regular weekly sessions which we have. And thank you, Soumya, for providing the platform. Thank you, MedPiper, for such a wonderful platform that